Every day, you essentially pay your dues by doing the harder thing when it's the right thing to do. How do we differentiate between normal dysplasia versus hypermobility versus like pathological instability and issues? Like, where's that line there?
Yeah, that's a great question. I wish I had a great answer. I like I do. I mean, I agree. Physicians do the same. I mean, I get the physicians doing the same thing. I think sometimes PTs and early in my career, I think I did the same thing as well.
Yep.
It's a gymnast where you're lax versus that's what got. I mean, that them having that amount of motion is what is making them successful.
Yeah.
And the example like I always give is a large femoral head, so FAI impingement. And that tends to stop growing when the growth plate is closed. And so, and if this is a 25 or 30-year-old athlete, that they've had that for 10 years. Why are they having problems now? They've had problems for 2 months. And so the easy blame is, well, it's the femoral head. I can see it on the radiographs, right?
Yeah.
Or I can see the shallow hip. But yeah, they've had that for a long time. Why are they having problems now?
Yeah.
And so differentiating that, so like I look at Bain scale, I mean, and look at it overall. That said, is you could have probably not in the individuals you're seeing, and they're probably high on Bain scale, I would assume. But it's muddy, and like I look at subjectively, and I think it's important to differentiate hypermobility versus pathology, right, or instability. So if they're just generally high on Bain scale and they have a lot of motion, and they don't have pathology, I mean, then like if you look at ballet dancers, there are studies that show that I think 90% of them have a snapping hip, but they're all asymptomatic.
Right.
And then some people would argue, well, that sets them up. Well, I don't know. I mean, maybe, but I think the big thing is symptoms, and that symptoms that are consistently with same types of movements.
Yeah.
And in that case, then I'll just like I can't change the shallow hip. I can't change the fact that they're going to do ballet. What I can change is the magnitude of the motion, the intensity, the stances with different activities, and try to gradually get them back to those activities. So
back. But I think that intimidates a lot of clinicians. I think that really large range of motion, if you don't understand the sport, is very scary to a new grad or someone working on a non-surgical or surgical hip. So it's challenging, but you have to realize what are the sporting demands.
No, I absolutely agree. And to be honest, like I was there, right? And my big thing early in my career is like I was seeing a lot of ACLs. I had this athlete that was just smoking through rehab and doing really well. I mean, it was mostly due to them. We got to 9 months. We didn't have isokinetics. We had handheld dynamometry, and he passed that. And then he passed a KT Lockman, and the surgeon released him. He kind of came back, and I said, well, you're good. And he goes, I'm a wide receiver. We haven't run any pass routes. How do you know I'm good? And I thought, you know what? He's right. I mean, we did hop tests. Like we didn't replicate his sport demands. And so that's what prompted me to write my first book on functional testing with Mansky is like, what's out there? I mean, versus just like, what does he have to do? And can he do it? So.
Yep.
Granted, I see some fairly challenging cases just because of where they're coming, from the surgeon they're coming from, and it's always like guiding them and encouraging resilience and telling them, you know what, you're just sensitive in that position. I mean, you've had this dysplasia, if they're, you've had this for a long time. Like, why are you having problems now? And kind of like that first session is spending a lot of education on it. Is prior to 2 months ago, you were doing well.
Yeah.
What changed in that amount of time? And sometimes they know and sometimes they don't. And the other thing is we're not taking things. I mean, it's like I almost treat them kind of, like if I used to work a lot with runners, and if you tell them they're not going to run, like they're not coming back. Right. Yeah. I mean, and so like all my patients still squat. And like you said, is we might be front rack squatting, or we might be squatting in a Smith frame, or we might doing box squats with time under tension. We might not be doing a low bar back squat, to parallel right now. And then we're going to kind of gradually progress it and using like RPE times time or load, or, I mean, kind of getting some kind of auto regulation as well.
Yep.
And learning how to systematically progress that over a period of time. And sometimes we change stances, maybe not so much but like FAI patients, oftentimes going out to a sumo squat. Some sumo squat studies are showing that actually puts a little bit more load on an unstable patient. So like I tend to play with that and see. And then and I still do this sometimes where I'll change some things and they'll go, well, this is not what I'm doing, what I need to do in my sport. And I
Right.
know we'll eventually get there. Is my goal for right now is to keep the intensity, the load on you.
Sure.
And I've explained that, and to keep the load on you for, and then we'll change the position, we'll lower the load down, and explaining it how we're going to progress them through that. And because I think they need to understand is this is not a setback. This is just, we're going a little bit sideways right now,
Right.
and then we're going to still get back on, or we're still going forward. And the other thing too is sometimes the rehab takes a while, and I think what gets challenging for, like, a lot of times my students will email me or talk to me and say, yeah, come seeing this patient and this is what's struggling with, and people are plateauing and they're like, and I said, well, are you doing this? And you go, yeah. And I mean, sometimes I think the problem is if when people plateau is you're trying to figure out, am I still doing the right thing or do I need to change things up? Right. And so I think that's where sometimes having being in an environment like you're in and having somebody else, hey, Lenny, can you come and look at this? Or, and just, I think having, being in an environment where you can have somebody else take a look at it and or consult with somebody is very helpful too. I
Yeah.
think students and young clinicians are, I mean, they feel like they have to know everything, or they feel like they are admitting failure. I don't know if that's the right word, but like I consult, like I'm in a training room right now, and there's like, I mean, even though I'm an athletic trainer, like some of the taping things, like I'll go ask a trainer, like, what do you think we should do with this?
Yeah.
And yeah, and I think part of it too is being comfortable with uncertainty, which a lot of people say they are, but they really aren't. And it's just and being genuine with your patient is, what, in that case is like, we've tried these things. It seems to be stalling just a little bit. I mean, do you mind if I just get a fresh set of eyes on this?
Yeah.
And in the meantime, you've been getting a good therapy clients with a patient, and like I think patients generally appreciate that.
Oh yeah.
And I think it's how you sell it though too is right. I mean, if you go in there, God, I have no idea. Like I'm gonna go get somebody. Like that's not the way to sell it. But it's, yeah. I think every year I give my students I think it was Simkin that wrote it, is tolerating uncertainty.
Yeah.
And just, I always give them a talk about appreciating the gray versus the black and white. And that's part of it. And I think it's just being comfortable with being uncomfortable. And
Yeah.
so
I really
employers are always saying, well, yeah, we'll give you mentorship. And I tell them all the time is, what does that mean?
right.
Does that mean Friday, as they're walking out the door, they're saying, Mike, how was your week? Or are they, are you doing journal clubs? Or, I mean, are you set aside at a time? And because, I think the other thing too is, I think I don't know if you're familiar with Simon Sinek, but he
Yep.
talks about how, and he's not talking about PT students, but young people are like changing jobs because they feel like they're not making a difference in their job. And like my daughter is kind of in that age, and she's kind of the same way where I can see, like when I was her age, I was just like, I just want to get through school and figure out what's going on. And like, I mean, they have huge goals and like they want to be profound people, which is awesome. But if that doesn't happen soon, Simon Sinek was talking about, they want to get into a different type of a position or different change, and they see Mike, they see Lenny, they see Chad Cook, and like, I want to be there, and they don't realize that it took Mike and Lenny and Chad Cook, and like like I mean, I mean, I think Mike has mentioned this too. Like I failed my ATC exam the first time.
I got kicked out of PT school.
Did you really?
I did. I failed a clinical.
Wow. And so it's like they see us where we're at versus like what we've been through, right?
Yeah.
So, yeah, and so it's like we just, I mean, I very much appreciate how they want to be great and awesome, but just realize that sometimes it takes a little bit of time. I mean, some people, and then the other thing is they see some people, like we've had graduates that are like they're in the NFL within a couple of years, like,
Mhm.
and then so I tell them that story and they go, well, he's in the NFL and he's 2 years out. Like, okay, yeah, those things happen too. So
Yeah. I think I always make the joke with people that, I sacrificed mentorship for proximity of location and money. When I went early grad, I was like, these loans are heavy. It's closer to my house. Like, I'm just going to take this job because they said mentorship. And it was exactly what you said. It was like a part-time casual interaction. It wasn't real mentorship. And so the advice I always give the new grads is like, take a little bit of a less pay, more travel to get someone who's really going to help you. And that's why I would have changed jobs, obviously, for many other reasons. But one of them was that like Mike and Lenny are treating clinicians. They're in the trenches. They're always happy to help. They're learning. They're pushing themselves. But like, they're never afraid to, give some tough love sometimes and be like, hey, like maybe think about it this way or not. And I think like that's invaluable compared to anything else that you can get in another clinic. And so if I could go back and do it over again, I would sacrifice those two things for the mentorship. And I think people should maybe take it to heart, especially as we get into new grad season
Yeah,
coming up
that's a
here.
good thing. And I talk about this in the course, and I talk about this with my students. Is like I use some stairs, and what's level one, what's level two, what's level three, and if you start with level two and they start getting, they need to go backwards. Like how are you regressing it and or progressing it, and even like for example, I mean, and like you talked about before, is like knowing what was done. So if something was done and they seem to have some iliopsoas tendinopathy or something, like just simply knowing that the iliopsoas runs in front of the femoral head and acts as a stabilizer anywhere from 15 degrees of flexion to extension. So like and so so if you try to do heel slides at 0 and it's irritating them, okay, they can't do heel slides. Well, put them at 30, put them over a bolster,
Yep.
use a towel. Now they can do heel slides, right? And so like knowing the anatomy, knowing what was done and knowing how to change it in versus like, well, they can't do squats, they can't do heel slides. Well, they can't do them that way, right?
Yeah, I think I don't know why this just popped in my head. The first time I really got that concept of like knowing what was done and where is when Mike and Lenny had presentations on like cartilage issues in the knee, like different parts of the trochlea engaging in different ranges. Like it's not that you can't use your knee, it's that like if it's on this part of the condyle, you can't go super deep. If it's on this part of the patella, inferior pole, you can't go super shallow. And it's like find ways to work around the range that engages it. But every joint, every surgery has that option of what you just said with iliopsoas or microfracture and weight bearing or issues like that. Like you have to understand how different procedures impact ranges, especially like the capsule and like ER and extension and stuff. Like there's a reason why for 6 weeks they don't want you to extend their hip too far, and some protocols, right, ranging. But there's a legitimate reason. I think sometimes we don't respect that and understand why or have a communication point, and then they get angry. The hip joint gets angry early, and then they get angry, I guess, as a result too. But those first 4 to 6 weeks are really like kind of sometimes protecting them from themselves and educating them about like pick your leg up, like don't slide your foot too far. Like when you get out of the car, don't lean your way over and cross your body and stuff like that. Like little things like that, they probably don't realize are keeping their hip sensitive for longer periods of time.
Yeah.
Where do you see maybe the ball is being dropped in some of the advanced phases of strength and conditioning, and what can clinicians stay on the front curve of for not letting them go back too early when they're not strong enough or they haven't done any workload management?
Yeah. I mean, I would, yes, I agree. I think, it's, I mean, if you look at the outcomes, I mean, simply the outcomes, like we did a systematic review, meta-analysis showed that 74% of people are actually going back to the same level.
Yeah.
But then a group of my colleagues in Denmark showed that only about 20% are actually going back to the same level, satisfied and performing. I mean, for the reason that they had the surgery, less, 2 out of 10 had this goal of doing surgery to get to this, and only 2 out of 10 of them are getting there. So 10 out of 10 had the goal. But and then if you look at even non-athletes and you look at patient-reported outcome measures, like they're typically about 80%. And then another Denmark study showed that even the people that are satisfied, they're not as active as they were prior to surgery. It's like, what is going on? And so, I think I think there's a lot of reasons, right? I think it's perhaps we're not as good at, maybe that's, we're not, kind of the considerations that, do you need to send them to somebody else?
Yep.
And or do we have enough time? Do we have enough insurance? Like all that depends. But I think it's. I mean, I like to look at Vermeil's hierarchy, and are we addressing all those things? And are we, do they have a good foundational base of capacity? And then are we progressing? What kind of a sport? If they're an explosion sport, are we truly working on velocity? Are we working on speed strength? Are we utilizing energy systems? Like when my patients come in, even when they can't do their hip stuff, like they're on the UBE or the Airdyne bike, and we're replicating work to rest ratios.
Yep.
And we're doing that all throughout the rehab, and we're building we're periodizing.